Sorry, we've got no sound.
Its national partners are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@CAHN.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, ladies and gentlemen, and welcome to our CATHIP, session again. And this morning, we're really delighted to have a very important topic. And we have our esteemed speaker here, Dr. Patrice Atta, who will be taking us through that. But we're very, very grateful, to have our partners. So CATHIP is delivered by a couple of organizations. They're all Black-led, working up and down the country to ensure that, Caribbean African people and the wider community are living longer and our outcomes are better as well. So in this partnership, we have RAFA International Development Agency. They're based in Birmingham, but work across the country. We have Croydon BME Forum. They're based in South London. Enfield Caribbean Association in North London. Black Health Initiative in Leeds. And then the RCCG Royal House Chapel in Sheffield, as well as the Caribbean African Health Network. These sessions are designed for you to learn, for you to engage with the clinicians and ask a lot more questions. And this morning, as we go through the session, feel free to tell us how you heard about, this session, because we put out some jingles. We want to know whether the community radio investment is paying off, but also it's great to see you. And just to remind you as well, every Saturday morning we have these sessions. So next Saturday we'll be looking at sepsis, which is also a big killer, across all communities. But for this morning and the early part of the afternoon, I will be your host. Apologies from Dr. Vanessa, who's had to cover a clinic because we all know the rising cases in monkeypox, and she's our sexual health lead, and she's also a consultant in sexual health. But I'm going to hand you over to the capable hands of Dr. Patrice Atta, who will be covering the menopause. And when she's done, we will be taking questions. At any point in time, feel free to drop your questions in the chat box. If you want to send them to me privately, feel free to do that, or any other person with CAHN in brackets by their name, and we will fill that. And welcome to all our viewers also on Facebook as well as YouTube. We have staff and colleagues engaging on there as well, so feel free and post your messages in there. Dr. Patrice Atta, many thanks for giving your Saturday morning. We know how busy the week is for all of you, so we're very grateful, and over to you.
Thanks, Charles. It's a pleasure to be back. I'm going to share my screen. Okay. Don't know if you can see it now. Here we go.
Yes.
Okay, so great to be talking about this very important topic again. And the menopause sometimes draws negative connotations, but I'm glad that we can talk about it this morning. I'm glad that we're hearing more and more about the menopause in the news, so we're becoming more open to discuss about the menopause. So what are we trying to cover today? So we want to define what it is. We want to talk about the racial differences and experiences that women of color have. We want to understand the hormonal and physical changes that can occur with the menopause, because we know that once we have that information on board, we are better equipped to deal with these signs and symptoms. Okay, so we want to talk about managing how we manage those symptoms. A big topic of the menopause is HRT. So I want to discuss about that as well, and the use of alternative remedies to HRT. So what is the menopause? Unfortunately, it can coincide with many major life events. And because of that, and because society is a society that kind of promotes the young, fit, lean person, as you're going through the menopause, majority of women go through the menopause, start having symptoms in their 40s and 50s. There are some negative connotations to that. It can coincide with the empty nest syndrome. The kids leave for university, retirement, financial insecurity, onset of major illnesses, care for aging parents. And on top of that, you have all the hormonal issues to deal with the menopause. So there are some negative connotations to that, but this morning we hope to break that trend of thought. Some interesting facts about the menopause. 80% of women suffer from some sort of symptom. 45% find their menopausal symptoms distressing. 80% experience hot flushes. So that kind of burning sensation that you get, very hot, feeling very hot and sweaty. About 30% experience vaginal symptoms in the early postmenopausal period, and about 47% experience vaginal symptoms in the later part of the menopause. But only 10% of women seek medical advice. So even though we have all these symptoms, women are going through all these symptoms, they kind of suffer in silence, suffer alone. And so our aim and objective is to speak more about it so that women can start accessing this medical information. So what is it exactly? So it's derived from the Greek word men, meaning month. Pausis is cessation, so the end of your monthly periods. And it's defined as 12 months of no periods or amenorrhea. So it marks a time when the ovary stops functioning, and hence it marks the permanent end of fertility. The average age in the Western world is about 51 years of age. But we know that some women experience premature ovarian failure, about 1%, experience it less than 40 years, and even less experience it less than 30 years. So various women, age groups can undergo the menopause. Now, the perimenopausal period is that period of time where the transition period can last a few years. You get that change from the normal cycles to complete cessation of your periods. Periods become irregular, the cycles become shorter, and you get that onset of menopausal symptoms. So this is a little diagram, schematic diagram of the hormonal changes and what goes on in a normal cycle. And the hormones to note are your estrogen, okay, your progesterone, and the fact that the estrogen kind of stimulates the endometrial lining. The progesterone, when it's at its highest peak, it kind of thins down the lining of the endometrium. You have your hormones such as your follicular stimulating hormone that is responsible for development and maturation of the egg. And you find these the level of FSH is quite high in postmenopausal women. And I'll speak about that hormone a little later on. You find some clinicians actually testing FSH to kind of diagnose menopause, but we'll talk about that in a bit. So it's just important to kind of have an idea of what these hormones do and how they're involved, so important in our well-being as women, especially estrogen. So what are the racial differences? Well, there was a study called the SWAN study. It's a study of women's health across the nation. This was done in the US. I think it was published 2018. It found that women of color enter the menopause at an earlier age than their white counterparts, and they have a longer transition period and experience more what we call vasomotor symptoms, the hot flushes and the night sweats. They found that they actually, the duration of the hot flushes and night sweats were actually longer in Black women. So 10.1 years of having these symptoms as compared to their white counterparts. The other racial differences they found, Latino women have more complaints of vaginal symptoms, and Native Americans have more hot flushes than any other ethnic group, actually starting quite early in their 30s and 40s. So it does vary by ethnicity. But in particular, as Black women, we are kind of prone to having longer symptoms and more intense symptoms. These hot flushes and night sweats are more intense. As I mentioned, they take longer, we take longer to transition and can start bleeding irregularly at a younger age. Now, obviously the implications of this is that you have the biological effects of menopause, where you have the bone density declining, increase in fat mass, decrease in muscle, and increase in cholesterol. So all these things, physiological changes, happen at the time of menopause. So they all occur earlier in the Black woman. And therefore, you have an increase of osteoporosis, heart disease, and falls. So why this disparity? Well, one of my theories is that Black women suffer more from symptoms of period irregularity, such as in fibroids, endometriosis, adenomyosis in the first place. So we already have a high incidence of these conditions. And the authors of this study came up with a theory called allostatic loading. So the body is at an equilibrium. All our physiological processes at an equilibrium, and the body tries to maintain that kind of hemostasis. And when we suffer from stress or pressure, we tend to go outside of that normal range. So our blood pressure goes up, our pulse goes up. And with more chronic stress, it takes a longer time for that equilibrium to come back to normal. So as Black people, we know that we suffer a lot more from negative impacts of society, whether it's the microaggressions in society, whether it's that job that you've been working in for years and you can't get that promotion, whether it's your kids being bullied in school. So we have a lot of different stresses, more so than other ethnic groups. And because of that chronic effect on our physiological processes, that normal pulse, blood pressure is kind of disturbed. And they also found that there were higher levels of inflammatory markers in Black women. One of them they looked at was CRP, and it's related to life stresses and adversity. So it could mean that we lose the ability to react to new challenges or take a long time to calm down and come back to the resting state. So it's very important to understand that in our lives, that we have to seek relaxation techniques to help us come back to that normal equilibrium. As I said, people of color experience more trauma that goes with racism and poverty. And the thinking is that this leads to more allostatic load, and it's causing the disparity in menopausal outcomes. Women that are of disadvantaged communities have their final menstrual period much earlier. So this is something to consider. So what are the symptoms? Well, here I listed them. I listed the first one, hot flushes, because it occurs in the majority of women. But we can actually subdivide it into the earlier symptoms, kind of intermediate symptoms, and symptoms that occur much later on in our menopausal life. So initial symptoms will be things like irregular periods, hot flushes, chills, dry mouth and dental problems, dry skin. Some women speak about a kind of crawling sensation under their skin, fatigue, hair loss, inability to concentrate. So those are the more kind of symptoms you can get in the perimenopausal state. Now, at the end of your period, where the estrogen has completely stopped being produced by the ovaries, you can get symptoms affecting your bladder, causing bladder irritability, urgency, and also estrogen is important for maintaining the vaginal mucosa. So once that's lost, you can get vaginal dryness, and this could lead to painful intercourse, and that can affect your relationships. So other symptoms would be mood changes, metallic taste in the mouth, sleep problems or insomnia, weight gain, and slowed metabolism. So let's talk a bit about hot flushes. As I said, they can begin mostly in the perimenopausal time. You can get a sudden onset, reddening of the skin, feeling of intense heat, and profuse sweating. The intervals can vary, so it can happen once a day, much more often in the day, but it is more frequent and severe at night. The good thing about it is that they can generally stop spontaneously within the first few years. So they don't last forever, but they can persist for several years. About 12 to 15% of women suffer from these symptoms in their 60s, and just under 10% after 70. So they can be present throughout women's menopause. So how do we make a diagnosis of the menopause? So in women more than 45 years, we go by history of irregular cycles. And the symptoms, early onset of the symptoms of menopause, like the hot flushes, night sweats. Sometimes you find GPs doing, or doctors doing, the hormone test, FSH, but this tends to fluctuate, especially in your postmenopausal women, so it's not quite accurate. So it's best not to do FSH levels in this subgroup of women, more than 45 years of age, unless she's on contraception, where the contraception would kind of mask the actual hormone levels. And if she is, then she'll have to come off the contraception for at least hormonal contraception for at least 6 months before she does the hormonal test. However, if a woman is less than 45 years and starting to experience menopausal symptoms, that's quite uncommon. She'll need, we would usually do blood tests. So we do hormonal levels at least six weeks apart to see the pattern. So let's talk a bit more about treatment and how we would approach treatment of menopausal symptoms. I think I'll start off first with lifestyle modifications. I think that's the most important thing, especially in the perimenopausal period. And this is more things like diet and exercise, as we've been told about, kind of light aerobic exercises, simple things like walking, Pilates, that sort of kind of gentle exercise. That is actually a fantastic life modification. You get increased production of endorphins, and that is your body's own feel-good hormone. So your body has that capability of trying to reduce stress by producing endorphins. There are suggestions as in complementary therapy, such as acupuncture. There isn't enough evidence to suggest that that would help with hot flushes, but certainly it can help with other symptoms of the menopause, mood swings, things like that. Herbal preparations such as black cohosh, some of you may have heard of black cohosh, red clover extract. Of course, you have your soy preparations. These are sort of preparations that some women may like to try out first before going to anything medical. The phytoestrogens, including flaxseed, tofu, soybean. So the phytoestrogen are natural plant-based estrogens, and they kind of mimic the action of estrogen. And we'll talk a little bit about that shortly. Again, relaxation techniques, so important to help reduce our allostatic load and to help bring our body back into equilibrium after being faced by the outside world. So it's important that we focus on relaxation techniques. And we have cognitive behavioral therapy, which is basically talking therapy. It can be one-to-one, it could be in a group session, it could even be like based on apps. And basically, you recognize, yes, I've got symptoms, but the way you approach it, the way you manage it is discussed, and how you can kind of change your attitude towards these symptoms. So actually, it's been actually found by some studies to be helpful in women who say can't go on HRT, or who can't have any other alternative form of help with their symptoms. So let's talk a bit more about black cohosh. It's coming up in the news quite commonly. And if you go to pharmacy and look at their herbal preparations off the counter, you'll see black cohosh preparations. It's a woodland herb native to North America. However, they found that a specific preparation called remifemin can help reduce some symptoms of menopausal hot flushes. Other preparations don't tend to be that effective. So it can act as estrogen in some parts of the body. So if you've had a history of breast cancer, or you are at increased risk of having breast cancer, avoid. It could interact, it's metabolized in the liver. So avoid if you have liver disease, and you have to be mindful of drug interactions. So if you're planning to go on it and you're on serious medication like warfarin, digoxin, anti-epileptics, blood pressure medication, anything like that, please seek some medical advice before you start taking it. You can have some mild side effects, such as headache, rash, stomach upset, nausea. Other herbal remedies are compounds like ginseng, dong quai. Again, they can have interactions with some medication you're on. So please seek medical advice before taking those. And we've heard of evening primrose extract and red clover extract. These haven't been found to be, at least from the evidence that is there, and these are just based on small studies, small trials. They haven't been found to be effective in dealing with some of the symptoms of the menopause. Now, these are alternative drugs that need to be prescribed by your doctor. These are the SSRIs and the SSNIs are drugs that are antidepressants, basically, but in a very low dose. So it's not that we're treating depression. It's just been found that in studies that the low dose of these preparations can actually help some women with some of their symptoms of the menopause. Venlafaxine can help with hot flushes, especially so for women that can't go on a normal HRT, or for women that don't want to try herbal remedies, or that can't because of the medication they're on. Okay, paroxetine, you want to avoid that in women receiving chemotherapy. These drugs, though, can cause dry mouth, insomnia, basically, which is worsening of the symptoms if the woman is already having problems with that. And it could cause decrease in libido, especially paroxetine, sexual dysfunction. So again, if lack of libido is one of your symptoms, then that's something you'd want to avoid. Gabapentin results in a 46% reduction in hot flushes. You can also have some dizziness and disorientation. Another drug is Clonidine, and that should be avoided if you have a naturally low blood pressure. It causes hypotension. So basically, if you sit up, if you stand up from a sitting position, all of a sudden it can suddenly drop your blood pressure and you can be faint and dizzy. So it's, again, that's important, and it's something that your doctor will bring up if you are seeking some medical advice. So what are the specific concerns about drugs and the menopause and starting and being menopausal? One is irregular bleeding. That could be a problem on its own as women enter that perimenopausal period. Also contraception, and it's important that women realize that if they're on HRT, it does not protect you from pregnancy. Okay, it's not a contraception because the doses used in HRT are much lower than what's actually in the contraceptive pill. So these are things to note. Even during the menopause, as I mentioned, the hormone levels fluctuate. So it's important that you have that protection from pregnancy if that's what you want. You need that protection during that perimenopausal time, and even after the cessation of periods. After 1 year after your periods have stopped, they do recommend using contraception such as the condom to prevent unwanted pregnancy. So let's talk a bit about estrogen and why it's so good. It's important in a woman's lifespan. Well, it increases the oral estrogen, estradiol, which is E2 for short. It lowers your low density lipoprotein, glucose, insulin, lipoprotein. So your good cholesterol, it lowers your bad cholesterol, increases your good cholesterol, and it can increase triglycerides, which again can sort of promote heart disease, and as we mentioned, CRP. Okay, CRP being that inflammatory compound, that inflammatory protein. So the oral estradiol can have some effects, okay, on your body metabolism. And certain progestogens as well, which is the other female hormone, it kind of can offset some of the benefits of estrogen. So a study that you may come across when looking at whether you should go on hormone replacement therapy or not, the studies that have been mentioned again in the media, one of them being the Women's Health Initiative. I think that was published in 1991, where they looked at over 16,000 randomized women who were treated with combined HRT and versus placebo. And they discontinued that study because of a significant increase in breast cancer and cardiovascular problems. The main problem with this study is that they looked at older women, the mean age around 63 years of age, who already had atherosclerosis. So they already had heart changes, narrowing of the arteries. And that's why they were more prone to getting cardiovascular disease and strokes. So later on, they reanalyzed the data based on age, and they found that there was no increased risk seen in women between the age of 50 to 59, within 10 years of the menopause. They saw a slight increase in the risk of breast cancer with more than 3 to 5 years of use of HRT. An important thing to note is that the estrogen patch is another form of administering estrogen. It avoids metabolism in the liver and therefore avoids production of your triglycerides and your HDL, the bad cholesterol. So the patch actually, the estrogen patch, HRT, is actually better and has less side effect profile than, say, taking oral estrogen. And they found that it's best for women who have a history of migraines and epilepsy as well. So who do we recommend HRT treatment for? We recommend it in women with moderate to severe vasomotor symptoms. So those are symptoms such as hot flushes and night sweats. And we look at the individual risk of the patient and their willingness to accept risk. And we usually aim for the lowest dose of estrogen. Of course, adding progesterone if the woman has an intact uterus, and within the shortest amount of time possible. So that is the aim. Go for the lowest dose and treat for the shortest amount of time possible. That could be a year to 2 years. After a year to 2 years of treatment, women can start tapering off their dose. And if they find that, hey, I still need some help, I still need help with my symptoms, they can actually continue on with the HRT. So what are the types of HRT that we use? So most women would go on tablets, but as I mentioned, the patches have a better safety profile. Women can get implants, and there are also gels that are available. So what preparation should you use? And there's quite a lot of, there's a lot of information there about different preparations of HRT, and it can be a minefield. But basically, if you are in a perimenopausal period and you're still having your periods, you go on a cyclical HRT. So basically an HRT that has estrogen in the first half of the cycle, and then they add on a progestogen in the second half of the cycle. So you get estrogen and progesterone in the second half of the cycle. And the progesterone, the effect of the progesterone is basically to thin the lining of the womb, because we know that estrogen can increase and stimulate the thickness of the endometrium. And there's risk of the endometrium, if it gets too thick, if it gets above a certain level, there's a risk of endometrial cancer. So the progesterone is important in women with intact uterus to thin the lining of the womb and prevent what we call hyperplasia. So if your periods have stopped for a year or more, okay, we then recommend a continuous HRT throughout the cycle. So estrogen, progesterone throughout, it's continuous, you don't take a break, and you don't necessarily bleed on this preparation. With the other preparation, the cyclical one, you are likely to have periods. But at least it's periods that you can predict, and not the sort of irregular bleeding, because you don't want that when you can't predict when you're bleeding. It's much better to have a cyclical bleed. So there are women who shouldn't have HRT, shouldn't go on HRT. Women who have had breast cancer or endometrial cancer. We mentioned hyperplasia. So women who have that thickness of the lining of the womb that has not been treated, or has had vaginal bleeding that has not been diagnosed. It's irregular bleeding, infrequent bleeding, and they haven't found a diagnosis for it. Women that have had thromboembolic disease, so that's disease leading to blood clots in the legs or the chest. If you've had that in the past, then HRT is not for you. Again, inflammation of your blood vessels, diseases involving your liver, especially where your liver function tests have not returned back to normal. Obviously, if you're pregnant or breastfeeding, and if you're going for major surgery, you should be stopping your HRT 4 to 6 weeks prior to that, and restart when fully mobile to reduce the risk of getting clots. So this table is a little bit busy, but I thought it was important because it gives us the facts, and it gives us what exactly the risks are with HRT. So if you look at the very top column, you see the risk of breast cancer in the left-hand column, breast cancer, endometrial cancer, etc. The first row, 50 to 59, there is a background incidence of 10 per 1,000 of breast cancer. So this is women who are not on HRT. So there's that risk in the general population. Okay, that increases to 20. Okay, and for women that are on HRT or estrogen only HRT, the increased risk of breast cancer increases to 2. So instead of it being 10 in 1,000, it's 2. It's 10 plus 2, so an additional risk of 2. Again, for women who are on HRT using it for 10 years, that risk increases to 6. And for those women that are using combined estrogen and progesterone HRT, the additional risk of breast cancer is 6. And for those using it for more than 10 years, it's 24. So you can see that risk increases as the woman ages. So between 60 and 69, that background risk is 15 in 1,000, and 10 years beyond that, it goes up to 30, and so forth. So that the additional risk of breast cancer is actually still low. We always advise women who are on HRT, in fact, all women who are menopausal or have reached the age of 50 to have regular mammograms. So it's the hope that in that additional risk, it will be picked up by your mammogram. For endometrial cancer, the background risk is 2 in 1,000, and the additional cases per 1,000 on estrogen only, HRT is 4. And so again, it's a small increase. So we have to basically look at these figures in perspective when thinking about whether we want to start HRT. I think in majority of cases, the benefits of it outweigh the risk, because some women are quite debilitated from their symptoms. So what are the side effects? It's quite common to have headaches, breast tenderness, and some slight bleeding or spotting. And your doctor may need to adjust the dose or the type of preparation that you take to help you with these symptoms. Most of them improve within 2 to 3 weeks, but the majority of benefits can be seen within 3 to 4 months. So your first consultation should look something like this. Your doctor takes a history, confirms that you're going through the menopause clinically based on your symptoms. He checks your when your last normal menstrual period was, what your gynae history is, whether you've been having your smears, you're up to date with your smears, whether you've started your mammograms, and assess your risk factors for osteoporosis. Look at your past medical history, your family history of breast cancer, cardiovascular disease, and thromboembolism, and what contraception you're using. Again, he needs to do a basic examination of your blood pressure, height and weight, not necessarily a breast exam unless you've complained of a lump in the breast. So basically that's what they would go through with you when you first see them. They would then start you on a preparation if that's something you want, or they would then discuss with you your lifestyle modifications and what you can do as a woman to empower yourself and to make certain choices that can help your symptoms. And then they may review that in 3 to 4 months and see how you're doing with those lifestyle modifications. And it's a good time as well, that first consultation, if you want to start herbal remedies, to discuss it with your doctor to see if there are any drug interactions. So I think that women going through these symptoms, don't delay. It's best to seek early advice. I mentioned that HRT, we try it for a short period of time, sometimes 1 to 2 years, and we see the effects of it, the side effects, start creeping up after 5 years of use. There's increased rate of breast cancer, increased rate of, endometrial cancer. So some women may think, oh, I don't want to go through that risk. But within the first 5 years, the risk is the lowest. So stopping HRT, you don't want to stop it abruptly, because that may lead back to return of your symptoms. You want to taper the dose down and first go to the lowest dose possible, because the hormones have different dosages, and they can start low and go up. So you want to decrease to the lowest dose first, see how that feels, and then decrease your pill by 1 per week. Again, assessing how your symptoms are. So in summary, let's be prepared for the menopause. It's inevitable. We know it's going to come. We know as in Black women, it can start up to 10 years before the actual period ends. So we just be forewarned. And we just need to be armed with the necessary information and knowledge on how to cope with it. The best candidates for HRT are women in their 50s or younger, going through a perimenopausal period, who've had their last period within the last 3 years, with moderate to severe symptoms, and we're going for the lowest effective dose for the shortest duration of time. We need to put into perspective the individual risk factors such as high blood pressure, smoking, excess weight, personal family history of blood clots and breast cancer, etc. However, we need some more data on our complementary medicine, our herbal remedies. But definitely lifestyle modifications are also the key to dealing with the symptoms of menopause. I found these websites helpful. The British Menopause Society, they have little video clips on the menopause and various treatments and remedies. The DAISY Network support group for women going through the symptoms at an early age, and the National Prescribing Center website. They have interesting decision aids for, what should I do or what should I take to help with my menopausal symptoms. So that's it. Thank you very much. And I'll go back over to Charles. Hello, Charles.
Thank you, Dr. Patrice, for that very insightful session. I can see the questions coming through really fast. Thank you very much. And I'm sure people have found it very useful. I'm sure Charles will join us shortly.
Okay.
Yes, thank you. So I'll just see some of the questions that have come through. Okay, so, and then if anyone has any questions, and if you want to, if you're confident enough to ask, you can just raise your hands and we can unmute you to ask the questions. Okay, I've got one question here. So thank you very much, Dr. Patrice. Some women can't have oral HRT due to some of its risks to them, but HRT patch is offered instead. And I understand the concerns we have as Black women using medication for menopause, but the patch is actually helpful. So just to say, would you recommend that? Thank you.
Okay, so when as I speak to patients and as I read the literature, I think the patch is probably one of the best methods of delivering HRT. As I said, it's a patch that goes directly, the drugs go directly into the bloodstream, so it doesn't go through the gut. Doesn't go through the gut, doesn't go through the liver. So if you're having liver disease or there are a lot of drug interactions that can occur, going through the gut and going through the liver, they can have an effect on the production of substances in the liver as it goes through the liver to be metabolized. So if you can bypass that, that in itself would be of benefit. And they have found using the patch that the effects of the side effects, the bad effects of HRT are minimized. And women who previously couldn't go on HRT because of whether they had symptoms of migraines or epilepsy because of the medication they're on and the effects of that on the liver with the HRT, they found that this is beneficial, and women who have got gallstones as well, the patch is best. Now the patch can either deliver estrogen only or estrogen and progesterone. If it's estrogen only and you've got a uterus, you've got to remember to take that progesterone, progestogen, to help counteract the effects on the lining of the womb. And that progestogen can be delivered various ways, whether it's by tablets, whether it's by a Mirena device that is a device that fits inside the womb, and it just releases that hormone on the lining of the womb. It's not really absorbed systemically. So again, there are lots, and that also provides contraception as well, the Mirena. So looking at all the various preparations and the side effects, I think the patch is one of the best ones to use.
Okay, thank you very much, Dr. Patrice. I've got another question here. It says, what impact does menopause have on work performance?
Well, a grave impact, quite a grave impact, because it can cause memory loss. And I work with midwives, and I remember one midwife saying to me, she would be trying to, the words would be in her head, but she couldn't get it out. She couldn't speak. And you could imagine being in, women in their 40s, 50s, whether they're high earners or not, or in a corporate setting, and you're in a situation like that where you can't get your words out, or you're suffering suddenly from hot flushes and night sweats at any time of the day. So it can have a significant impact on your work, not just work, but relationships at home with your spouse, with your children. And remember that women can already be going through this these midlife problems, empty nest syndrome, dealing with various problems in their lives. So all those symptoms on top of that can lead to quite distressing period of time for women. So it can impact significantly.
Fantastic. Thank you for that, Dr. Patrice. I know recently there's been, you're the expert, you can help me here. I know there's been an act, the Health Act or something has been released recently around menopause. And just with what you've said and the question that has been asked, we just hope that that will help more women in the workplace and even at home for people around. Just, think of this and help your family members when they go through this. So Dr. Patrice, if you just touch on that new act for menopause.
Well, first of all, I'm not the expert, but I do see patients not on a daily basis with menopausal symptoms, but ever so often, because I also cover obstetrics as well. So I'm not too familiar with that act. So I will have to research into it and have a look at it in some more detail before I answer that question.
Okay, thank you, Dr. Patrice. So just another question. Someone said they're 56, postmenopausal, as periods ended around 4 years ago. I have fibroids and told they will shrink, but they have not. I have menopause symptoms like flushes, mood, urinal, dryness, etc. Is that all part of the symptoms as well?
Well, I'm glad you mentioned fibroids. That's one of actually the benefits of the menopause. So all the problems caused by hormones, cyclical hormones, when you were premenopausal, can actually improve once you're menopausal. So fibroids will shrink. Symptoms of endometriosis will reduce. Symptoms such as premenstrual syndrome, premenstrual disorder that could debilitate a lot of women, that can improve as well. And of course, no pregnancy as well. So those are the benefits of the menopause. And the second part of the question was, sorry, could you just repeat it again?
Okay, so just trying to find that. Yeah, so flushes, mood swings, urinal, and then dryness.
Yeah.
And then, it continues and possibly worsened by stress.
Mm-hmm. Yeah. Yes. So those bladder symptoms, as we mentioned, occurs those are the intermediate symptoms. So not the acute onset, but kind of happens when your periods have completely stopped. Okay, so that 12-month period when you don't see any periods at all, that's when they're at their worst. The good thing about the vaginal dryness and the bladder symptoms, they could improve with just local application of estrogen. So the estrogen vaginal tablets. Okay, that can help, and it doesn't get absorbed into your whole body. So if those are your main symptoms, then you can have targeted treatment for those symptoms. That's a good thing. So yes, you can have those symptoms kind of intermediate, but again, there's help. There's help for symptoms like that. So really advise you're struggling through these symptoms, please see your GP. If your GP doesn't feel comfortable prescribing medication for you because of your high risk factors or different risk factors, they can easily refer you on to a menopausal clinic. There's a menopausal clinic in Manchester, MRI, and various hospitals have dedicated menopausal clinics. And you can also, refer you to tertiary center for advice.
Okay, thank you, Dr. Patrice. The same person said they have consulted two GPs and they've had two conflicting advice from the GP. And the fibroids, one GP said the fibroids will not grow as much. Mm-hmm. And the other said they will grow. So they're quite confused. And just also, person mentioned that she takes sage, which doesn't help flushes, but I think she thinks it helps the memory.
The memory, right. Okay. So fibroids tend to shrink. That is the consensus with. If you find your fibroids are getting bigger, or your tummy, your abdomen is getting bigger, and you've got fibroids, that is where you need to seek medical advice, because they should be shrinking, because we know that they're estrogen dependent, and if your estrogen is declining, then by logic they should shrink. So if you find the opposite is happening, please seek medical advice so that further investigations can be done to find out exactly why they're getting bigger. I've seen, sorry, can I just ask, I've seen Elizabeth Cameron's hand up. Is it possible to unmute her so she can ask a question?
Sure, thank you. Angela, can you unmute Elizabeth, please? Thank you.
Yes, thank you so much. And Patrice, how lovely to see you again under these professional circumstances. Just it's a couple of things, because I want to be able to feed this back through the race equality panel, because we have a health and well-being area that we're dealing with. So I think it, just to be able to take back what you're saying there. And I found this morning really useful. So thank you to CAHN and yourself for today. I also work with the trade unions, and they do a tremendous amount of work around the menopause, because we see a lot of women almost losing their jobs because of their symptoms, either their mismanagement of menopausal women in the workplace, but also women themselves not recognizing that they are symptoms for an upcoming for a menopause taking place, but also an embarrassment, not wanting to take those things to the employer. Mm-hmm. And so on. So most trade unions have taken this up as almost all have campaigns. I would say all have campaigns to say that menopause is a workplace issue. It's a workplace campaign. So please do go around that route. If you're not getting anywhere, because it's not enough just to have a policy. People have talked about policies, but it's really I think many of us could talk about policies that have stayed on shelves. So it's about the actions that are being taken, and how that sort of frees up the woman to be able to be her whole self at work, to go through this with support. And, so you might need to expand on a policy, so just being a policy, if you don't see that bit in there that allows you to be able to continue to work through this, or that supports you if you have to have time off. For example, you might want to campaign around issues such as, 1 day a year or whatever, if you're on the menopause, can be discounted against your trigger points for sickness or whatever. Different workplaces will want different things and want to campaign on different things, but it's a suggestion. Do bring them alongside. It's very much a key area of the work. And the other one is purely personal. I got thrown into the menopause, was losing so much blood that they had to give me a hysterectomy, full hysterectomy. And I'm advised now that I should have fought stronger about having your cervix removed. And I wondered if you could say more about that, because we often, if you're thrown into it and for medical advice, you're being told to have a full hysterectomy, which throws you into the menopause. Would that have any bearing on the way you experience menopause? Because I was thrown into it full blast. And yesterday was persuaded away from patches and into gels, they said. So I hadn't heard of a gel before. So is this a new thing? And just give me your point of view on that, please. Thank you, Patrice. Thank you, Doctor.
Okay. So the first question about the hysterectomy, again, it depends on the age that you're having your hysterectomy and what you're having your hysterectomy for. So if it's for heavy, benign conditions like fibroids, heavy periods, and you're in your early 40s, your doctor, should have this discussion with you, whether you keep your ovaries or not, whether you remove the cervix or not. The advantages of keeping your ovaries there is that the ovaries are still producing estrogen. And although the menopause may occur 2 or 3 years earlier, when you've had a hysterectomy, it will still be kind of a gentle, more, I would say, gentle, systematic way of experiencing menopausal symptoms, rather than having your ovaries removed completely. Then you immediately get the effects of the menopause. So they should really pre-warn you, prepare you for that. Because if you're having hysterectomy and you're removing your ovaries, you need to start going on HRT right away, because you can start feeling the effects of that pretty soon afterwards. With respect to the gels now, the patches, I would say, one thing I didn't mention is that some people can't always tolerate the patches. It could irritate their skin. Some women don't like the fact they have to change it twice a week. The patches it's not for everyone, but they have developed a gel, and that gel you apply it kind of once a day, and it's just another transdermal preparation that is effective. So there's so many options out there, and it basically is your preference and what you can tolerate and what you're happy doing on a day-to-day and a weekly basis. Thank you.
Thank you, Dr. Patrice, and thanks, Elizabeth, for that question. I don't know, Charles, are you back now?
Yeah.
Okay, so
thanks, Ngozi.
Yeah, so I just stopped at the question about what impact does menopause have on work performance. So you can carry on.
Great. Thanks, Ngozi, for that. So, Dr. Patrice, someone is asking, I've heard Black women are more likely to gain weight than white women after menopause. Any advice about that?
I haven't seen any data on that weight gain. The data I did see with Black women is to do with their symptoms, such as the hot flushes, the night sweats, the irregular bleeding. That is increased in Black women. The weight gain is, I think, across all ethnic groups, and the menopause is kind of associated with a slowing down of your metabolism. So dealing with that, again, it's the light aerobic exercise, the walking, the gentle walking, just keeping up that metabolism that can help combat weight gain. Of course, watching your diet as well, stopping smoking. Those are the things you can do for weight gain at this age. It is a challenge, trust me, but it's doable.
Great, thanks for that. I will bring in Dr. Ambrose.
Yeah, hello everyone. Apologies to the women for talking on a women-focused issue, but I can assure you that we men are very much part of the support network when women experience a difficult menopausal period. I could remember my mom then. I never knew it was menopausal symptoms. She was complaining of nights where she can't put on clothes at night. She was becoming a bit irritable. I could see some sort of psychological changes in her. I've seen that in my sisters recently, and I have managed to advise them appropriately. Having said that, it's not all doom and gloom. Menopause to some women serves as a period of celebration. I know there are some African traditions, and in Canada as well, they look up to menopause. And also those who have been having premenstrual tension syndrome or polymenorrhagia, all those sort of things, is a cause for celebration when their period ceases. Having said that, I think the principal thing here is for women to prepare for menopause. It's a normal aging process. It's not a disease. So by the time you're turning 40 as a woman, you should start thinking, on the average, at the age of 48 in women from Nigeria, as research shows, they start going into menopause. So preparing for menopause is important. Preparing to probably eating healthy, exercise, stress management techniques. Some people go to Zumba dances, some people exercise, some people start reading about it, getting some information, attending groups like this. In mental health, we are seeing a lot of women attaining menopause earlier than expected and coming down with huge physiological and psychological problems. And many a time, many of them didn't prepare for it. So preparation is very important. And thank you for presenting this topic. It's an amazing topic, and men should be part of this, because if you have a very supportive man beside you, going through menopause becomes easier. It is never a disease. It's a normal process of aging. Thank you.
Thank you very much, Dr. Ambrose. You're really spot on, and thanks for chipping in. I'm learning a lot myself as well. Dr. Patrice.
Yeah, well said. And I'm glad Dr. Ambrose brought up the topic of that support. That support is so important. Even yesterday, I saw a couple in clinic for advice on HRT, and the patient came with her husband. And sometimes your close ones are the best advocates for you. If you're going through symptoms like memory loss and poor concentration, when you attend your doctor, you may not remember everything that you want to tell him. So it's good to have a little diary, symptom diary, good to bring someone with you that would be an advocate for you. And usually the questions I get a lot is actually from the partners and the mothers of my patients. So it's good to have that support network with, rooting for you.
Thanks, Dr. Patrice. I'm going to bring in Joanna.
Hi. Great topic. I heard you say something about ovaries. I had one of my ovaries removed about 3 years ago, but I wasn't told that I would go through menopause from having it removed. I do eat healthy-ish. And I do exercise, so I cycle a lot, do a bit of yoga and all of that. I don't really have problems with menopause, yeah, I might have a night sweat here and there, but at first I had it would pour like viciously, and I'm like, oh my gosh, I'm so hot. Next minute I'm cold. But on the whole, I do say that I manage it, and it doesn't manage me. So that's what I would bring to the forefront. And I do recognize that if I eat bad, then I get a lot of sweats. So then I observe what I'm eating, and I have like callaloo a lot, which helps with iron. And yeah, so for me, I don't have it as bad as like other people do. Like I see some people and they're raining with the sweat. So yeah, that's my contribution.
Okay, thanks for that, Joanna, because that is a really good example of you taking your health into your hands and working with what you've got. So if you know that your callaloo and your native foods are rich in iron is something you like, go for that. But I like the fact that you said that your symptoms just lasted a while, and in a lot of women, the hot flushes and night sweats just last for a year or two. They're the worst, and then they calm down as their body adjusted. So again, it's how you approach these symptoms and your mindset towards it. And I'm not saying it's all in the mind. It's not, but it's how you manage them, and how much you prepare for it. So as Dr. Ambrose says, it is not a disease, it's a phase, just as when you first started your periods when you were 11 or 12, you got advice from your auntie, your mom about the periods and what they are and what to expect. So it's the same thing with the menopause. We need to kind of prepare ourselves for it before it actually starts happening, so we're not in a disarray when we experiencing those symptoms.
Thanks, Dr. Patrice. Someone is asking about, diet and menopause. And I know on Tuesday we have a healthy heart session. So I encourage you to join in from 6 p.m. If you don't have the details, drop us a line, health@cathn.org.uk. But someone is asking whether there are any types of food that could help reduce the symptoms rather than using medication. And also we have another one you didn't refer to, our Black women attaining menopause a lot earlier. Someone has sent a message about her mom having hers in her 30s. Another has messaged as well. I started mine from the age of 38. I'll be 57 next week and have my hot flashes, and it keeps getting worse. I exercise, go to the gym 3 to 4 times a week. I've been on warfarin for at least 30 years plus, and various other medications. I had hysterectomy 12 years ago. So far, I've had nothing back that can help me. I don't need CBT. So what advice can you offer?
Right. Okay. So again, that is because you're on, warfarin for such a long period of time. I would suggest that you seek advice from the experts, because there are doctors that just deal with the menopause. Okay, they run menopausal clinics in MRI, and I suggest that your GP would refer you to that, because there are alternative prescription medications that you can try. I think I mentioned the SSRIs and the SSNRIs. So that is something an expert in the menopausal area will need to counsel you about. But do keep up with the exercising and the gym, because I think without those interventions, your symptoms would be a lot worse, and a lot more. So this is definitely a case where you need to be referred on to tertiary advice.
Great. I know we coming closer to our time. I've got lots of questions. So if it's okay with Doc, we will, continue for a few more minutes. But someone is asking whether it's possible to go through menopause and not know it. And another is asking whether, someone is really concerned that their fibroid, it isn't reducing, so what would your advice be?
Okay, so you would definitely know it, because even if you don't have those sort of vasomotor symptoms, that 80% of women having in the 20% that don't have those symptoms, your periods will definitely stop. So that would be, the number one, that is inevitable. Our ovaries are just have a finite number of follicles. And once those run out, then our ovaries stop functioning the way we know it. They still produce androgens, which are like male hormones, but for the most part, they have stopped. So you will know it. And the question about the fibroids, if you think your fibroids have not reduced in size or they're getting bigger, again, seek advice from your doctor to actually do an ultrasound scan and exactly see what the fibroids, where they are, how big they are. If you've got a previous scan, they can compare the sizes. If you are still having symptoms from the fibroids, such as heavy bleeding, again, you'll need to see a gynecologist about that. Because, as I said, it's logical that the fibroids should be shrinking. And if they're not, you would need further investigations.
Yeah, thanks, Dr. Patrice. Yvonne is commented in the chat box saying, there are specific experiences of Black women associated with the risk of HRT, and is therefore saying that in some cultures, menopause is not medicalized. So any comments from yourself in relation to that?
You don't have to go on HRT. That is not a must. It's there as a choice, an option, if the other alternatives and if the lifestyle modifications don't work. It is there if, as I said, there's some women that they can't go on it, they're contraindicated. And medically, they just can't have HRT. So it's not for everyone. And that's what we need to realize, that the menopause and the symptoms women experience is quite an individual, on an individual basis. And you should seek advice from your doctor with regard to your individual circumstances. So, it's not a blanket treatment for everyone. It needs to be tailored for you.
Okay, thanks, Dr. Patrice. Someone is asking, how long do you go through that for, in terms of some of the symptoms, but also you did refer to Black Cohosh, and someone is asking whether that's available on prescription. And just for our audience, time and time again, we know there are people who would have tried one herbal remedy or the other that may work for them. But what we say, and especially for our clinicians, and I'm sure you all understand that unless something is gone through the rigorous, scientific trials, then, our clinicians will not be able to. But on one-on-one conversations and looking at medical history, then it's a lot safer, to give some of that advice. But is Black Cohosh on prescription? And also, how long does the menopause continue for?
So, fortunately, the menopausal symptoms, the acute and the intermediate symptoms that we spoke about, they dissipate. So some people, it's all individualized as well. They would have it for 3 years, 5 years, 10 years. I think I mentioned, is it 9% of women in their 70s will still be having some symptoms. So for the majority of women, they do resolve in the 50s and the 60s. So that's a good thing. The Black Cohosh is not available on prescription because it's not one. It's not one of the alternative medications that's been recognized by our our medical bodies, and it is a herbal remedy. The concentrations, the dosage varies from preparation to preparation, so it's not standardized, and that's the problem with herbal remedies. It's not standardized across the board. Whereas if I take HRT in US, if I take HRT in UK, in Europe, and they say it's a dose, it will be that dose across the board. So that's a problem with herbal remedies. And as I said, you need to be careful with these herbal remedies because you may think it's all natural. But if you have certain conditions, these herbal remedies could mimic estrogen. So if you have certain conditions where you shouldn't be taking HRT, then you shouldn't be taking black cohosh and preparations like that.
Thanks, Dr. Patrice. Someone is asking whether there are studies that have African and Black, women that have been part of the study in relation to some of what we're discussing. But also from Susan, how well is early menopause, especially with Black women, recognized by health professionals, and asking whether they're more likely to be turned away because they think, it's something else, especially mental health related.
Mm-hmm. That is the problem. We need more education amongst our health professionals to make them more aware of these increased health problems in Black women. And I think this is the first step by health professionals coming to talk about it. And we need to educate our colleagues about that. And yes, a lot of women can get, it can be confused for mental health issues and depression and anxiety. It could be confused with that. And I guess that's where education is so important for the woman. And I'm so glad so many of you are here on this chat, because these are things you can speak to your GP about and challenge that concept. So yes, definitely we need more of our colleagues to know that the symptoms can be more prolonged in Black women, and they can start at an earlier age in Black women.
Thanks, Dr. Patrice. And I think Yvonne is back saying that occasionally HRT can cause fibroids to grow and bleed as well. I don't know whether you have any evidence-based or there's a comment on that.
HRT has a very low dose of the estrogen, of estrogen, especially compared, say, with the oral contraceptive pill. So it does have estrogen in it. Technically speaking, it can stimulate the fibroid, but again, it depends on the individual. There are alternatives to HRT. If you think you have fibroids, or you have fibroids, you don't necessarily have to go on HRT, but there are alternatives, as we mentioned before.
Great. I'm going to bring in Evangelist B. I think you had your hand up earlier on. Can we unmute Evan? Yes.
Good afternoon, sir. Good afternoon, Dr. Patrice. God bless
Hello.
you, sir. God bless you, ma. Yes. My question is...
Thanks, Ngozi, for that.
Oh, sorry, I'm watching from YouTube. Yeah, my question, sir. I'm just 42 years old. I get very weak. For the past close to 1 year now, I get very weak. I sleep well, but when I wake up in the morning, I feel dizzy, I feel weak. I've gone to the hospital to talk to my doctor. They carry out some tests, but everything is okay. And she put me on anemia drugs for 3 months. Then after that, I stopped taking it, but I still feel weak. I'm not doing any strenuous work, so I don't know what is responsible for that.
Yeah. Okay. So, you said you've had various tests done
Yes.
by your doctor. So
Yes.
they did your blood pressure, they did blood tests,
Yes.
they gave you tablets for anemia, and
Yes.
I don't want to assume, but do you think it's related to your periods or your lack of periods or irregular cycles or anything like that? So I think the most important thing that your GP can do is to get like a full history, because that's what I would do, of everything that's going on, from your cycles, from your smears, for your past medical history, family history, everything. I think you just need like a thorough history and examination and investigations as well.
Okay.
Okay, Dr. Patrice, someone is asking about the gel compared to the patches with respect to the risk you discussed.
Right. Gel versus patches, they both have similar effects on the symptoms. Okay, so they're both effective for menopausal symptoms. So they would help with your night flushes, hot flushes, night sweats. They would help with your memory loss and concentration. So they're both good for women who have had or gallbladder disease or on certain medication like epileptic drugs. So they're good for that. The difference is in your preference, basically. Some women can't tolerate the patch. They can get allergic reaction from that. When I say allergy, I mean like, a rash, an irritation. Sometimes it doesn't absorb very well in women through the patch, but the gel is invisible. You just rub it in your skin and it disappears. You don't have to walk around so that everybody knows that you're on HRT with a patch on. So it's more discreet. So those are the benefits. It's all to do with choice and how much they have enhanced the whole HRT experience, and it's good to have choices.
Thanks, Dr. Patrice. I'm conscious that we have, attendees from all over the country. And there was a particular clinic you mentioned about in Manchester. So if someone lives in Leeds, Birmingham, London, what should they be asking, their GPs if they have any concerns?
Yeah. So there are menopausal clinics. So clinics that where a doctor has, they've gone through training, a special module in the menopause, or they have done some training through the British Menopausal Society, and they see women on a weekly basis, and all the women are there just for those for that question in mind. How can I help my symptoms? What can I do for my menopausal symptoms? So they are set up specifically for that. They're usually located in tertiary centers, but you can have doctors with a special interest in the menopause located in your district general hospitals. So I would advise ladies to ask their GPs for referral to these, and most GPs would offer referral because most GPs are let's say sometimes it can be difficult, especially if a woman has had various history, breast cancer or a stroke or any concerns of that, or medical history. Most GPs would refer on to the experts for advice, because there's just so much information out there, and there's just so much, their risk, and these need to be taken into consideration.
Thanks, Dr. Patrice. Someone has asked a question, sir, and I'm quite interested. Do you realize men do go through the menopause as well?
Probably not physiologically. Probably not physiologically. Yeah, that's all I can say.
Yeah, thanks. Right. So I'm going to bring in Dr. Ambrose back, and then I'll pick one more question from the chat box. And also just to say to our listeners, if your question hasn't been answered, what we'll try and do is get Dr. Patrice to provide some written responses to all the questions that we are unable to answer. And if we have your email, we will drop you a line. But feel free to email us health@CAHN.org.uk, or we have a helpline that you can follow up with the text. One thing we ask for from our clinicians is that they will make time and provide a second opinion and on a one-to-one basis. And I'm sure they will be inclined. But I'll bring in Dr. Ambrose, and then we'll pick one more question and then look to provide written responses.
Sorry, I had to come in again because this one relates to men now, so I can confidently talk about it.
Okay.
This is when I was doing public health, I was working in Oxford University. I was doing a lot of systematic reviews and meta-analysis. I used to teach international students. I think one of the students asked me this question: do men go through ovulation and menopause? So I laughed about it. So that made me research into male menopause, what they call andropause. It's a very controversial topic. Unlike Dr. Patrice said, there isn't a lot of physiological or psychological symptoms associated with aging in men when their testosterone levels might be low. And this drop in testosterone levels do not occur in every man, whereas it's very likely every woman might undergo through menopause. Issues with sexual satisfaction or loss of libidos or declining feeling of general well-being can be associated, or low mood, with reduction in male menopause, but otherwise there isn't, like Dr. Patrice said, any physiological or psychological significant symptom burden associated with it. So women are somewhat lucky. Thank you.
Thanks, Dr. Ambrose. Dr. Patrice, someone is saying, I had my polyps removed and never saw my periods again. What could have happened? And someone is asking about herbal teas. I don't know which ones you could recommend.
So polyps were removed. Again, I'll have to ask around what age was that, because that could perhaps have coincided with with the menopause. If it's in the early 40s, that should be strange. But if it's because we do know that it's important, first of all, to remove those polyps. Those polyps shouldn't be there. We need to make sure that it's not early stage endometrial cancer. So it's important for that to be removed. But for your periods to stop because of that is a bit unusual. It could just be, coincide with the age, because that shouldn't affect your hormonal levels, okay? And it's your ovaries, the hormones, that the fact that your follicles are depleting, and that is the cause of your kind of fluctuating estrogen and progesterone. So yeah, I'd like to, it would be interesting to know the full story, the full history of that.
Thanks, Dr. Patrice. Two more for you, and the rest will make sure we get a written response. Is it true you need to prepare your kidneys for the menopause, and then link any advice on hair loss during the menopause?
Kidneys, not necessarily. You should be looking after every part of your body, really, when it comes to your health, but not specifically your kidneys. Hair loss, again, some women find that as one of the symptoms of the menopause, actually losing hair and thinning of the hair. Again, there are lots of different hair creams and hair oils and stuff like that to help with hair loss. Again, that is one of the unfortunate symptoms of going through the menopause, actually, that shift in the hormones, that increase in the, some women have the androgens, that little increase in the androgen profile, which is like the male hormone. Sometimes an excess of that can cause hair loss and kind of some areas of baldness. So again, that is something you would need to see the GP about, or your trichologist about, with help in that area. Very tricky area here.
Thanks, Dr. Patrice. I'm going to bring in Ngozi, and then we will hand that over to Daniel to wrap up. But just to say massive thanks, everyone. Next week, the topic is sepsis. We know it's a big killer as well. And, you know, if we've not answered your question, drop us your email in the chat box privately, or, you know, to everyone. And then we will make sure we come back with some written responses. Ngozi, over to you.
Thank you, Charles. Thank you, Dr. Patrice. Just to touch on the person that had the polyps, I just want to share my own experience just quickly. And just rightly, as you said, in terms of it could just be a coincidence, because when I had my polyps, it was obviously to help with certain reproductive matters. So I had my polyps removed, and I also had ovarian building, and that actually helped. And it helped with the condition I had. So just to buttress that point, that you know, that it could just be coincidental, and yeah, just sharing my experience, it did help me on all aspects.
I know that polyps can cause irregular bleeding, okay, because the surface of the endometrium is increased, and you can have irregular bleeding from polyps. So if that's removed, then your pattern of bleeding should get regular, should get better. Whether it goes completely, you know, that I can't say. I think that is mostly coincidental if your periods go completely.
Great. So, Dr. Patrice, the last one, someone, I think you've touched on it, but someone is asked, you know, in relation to sleeplessness and restlessness at night in relation to the menopause, and then any final closing words.
Sleeplessness and restlessness, yeah, a common problem. So women having these symptoms around that age, they might be thinking that might just be their only symptom, apart from the slowing down or lack of periods, and that may be their only troublesome symptom, or it may be in relation to the hot sweats and the night flushes. Again, lifestyle modifications can help. Wearing cotton, wearing linen, light clothing, making sure your room is cool. All these things these little modifications can help some women with making sure your bedding as well keeps you cool. You're not sleeping with a thick duvet on you. These can help with your symptoms. So meditation, some prayer before bed, all these things can help. And as I said, if you think they're not helping you, want to move on to medication, HRT or otherwise, that's something that you can discuss. It is a valid symptom to actually start HRT for, or start medication for, and a consultation with your doctor is the best way forward with that.
Dr. Patrice, we're really grateful, you know, for your time and such insightful, engaging, you know, presentation. And we want to say massive thanks to Joanna, to Elizabeth, to, you know, Evangelist B, to Ngozi, and all our women who have been bold enough to share their experiences, but also to ask questions. And whoever said we're hard to reach, you know, that is untrue, and we're disproving that. So, Dr. Patrice Atta, many thanks once again for your time. For all those whose questions we've been unable to answer, we will make sure we're in touch with you with, you know, via some written responses that Dr. Patrice will kindly provide for us. Next Saturday, it's on sepsis. And I think later on in August, we'll be looking at hysterectomy. We have a couple of other women's topics coming up. I'll leave it there, but I'll hand over to Daniel to wrap up. Thanks.
Right, thanks, Charles. Massive thanks to Dr. Patrice for this informative session on menopause. Doctor, thanks so much for your wealth of knowledge, and we've learned quite an awful lot today. We truly appreciate it. Massive thanks to our wonderful chair, Reverend Charles, and as well to Ngozi for helping out, for hosting the Health Hour session in such a brilliant manner. Big thank you to all our CATHIP partners and to all our attendees on Zoom, Facebook, YouTube. And you can actually access Dr. Patrice's slides for today's session by emailing health@CAHN.org.uk. So we have some exciting upcoming events to share with you. We are back again next week, Saturday, same time, same link, for our CATHIP Health Hour. And the topic is on sepsis, and this will be led by Dr. Kamara. Please register by emailing health@CAHN.org.uk. Okay, join us for our Healthy Heart session this Tuesday, and the topic is on healthy eating in pre and post menopause, and this will be led by Dr. Olusi. Next slide, please. Join us for our Black History Month on the 28th of September 2022, and this is going to take place at the Manchester Cathedral. Please register by emailing event@CAHN.org.uk. Next slide, please. Please join us for our prestigious fundraising gala event, which is also going to mark our 5th anniversary on Saturday, 22nd of October, 2022, and this is going to take place at the Deansgate. Going to take place at Hilton Deansgate, Manchester. Please book your ticket by following the link as you see on the slide. Next slide, please. You can join our counseling services and family and advocacy support services by emailing us again on help@CAHN.org.uk, or you can call us on 07710 22382. Next slide, please. Please do get in touch with our CATHIP partners if you are in their region. Caribbean and African Health Network, Black Health Initiative, that's BHI, Croydon BME Forum, Enfield Caribbean Association, the Royal Assembly Redeemed Christian Church of God, RAFA International Development Agency. Thanks everyone, and enjoy your weekend. Bye for now.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@CAHN.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.